Please continue a big round of applause for Dr. Saurabha and Dr. Shashank, who was on the piano. Both are from MS Hanumaiah. Thank you again, Dr. Saurabha and Dr. Shashank. We begin today's program. I will request our secretary, Dr. Harish, to honor the president, Dr. Venkatachala, with the medallion. May I now request Dr. Venkatachala, President of the Surgical Society of Bangalore, to deliver the welcome address. This will be followed by the lamp lighting.
Ellarigu namaskara. Good evening, dignitaries on the dais and esteemed members of Surgical Society of Bangalore. It's a wonderful feeling that we have gathered again after a gap of 2 years. Whenever we reach out, he is always kind to oblige us and join our programs. But unfortunately today, he will connect with us online because he is not in Bangalore, he is in Delhi at a conference. I would like to extend my warm welcome to our beloved President of ASI, Dr. Abhay Dalvi. You made us very proud, sir, by being the next President of ASI for the year 2022, representing Karnataka. I would like to extend a warm welcome to you, sir. Dr. Siddesh, sir, is kind enough to come all the way from Mysore. I would also extend a warm welcome to all the esteemed members of Surgical Society of Bangalore, all our executive committee members, without whom the whole year's activities wouldn't have been running smoothly. The sponsors for today's functions, Newmed Diagnostics and Mata Associates and Microlabs, who supported the CSCP. I would also invite the press club who are going to gather here to cover the event. Our office staff cannot be forgotten. Glenn and Kumar, they are always there with us in all our functions and activities to run it smoothly. Thank you, everybody.
Thank you, Dr. Venkatachala. We now ask all the dignitaries on the dais to join us for lighting the lamp. May I invite Dr. G. Siddesh, Dr. H.K. Nagaraj, Dr. Rajshekhar Reddy, and the office bearers of Surgical Society of Bangalore to join for the lighting of the lamp.
Sorry, I forgot. I had written it, but I don't know how I forgot now the orators for today's evening. Dr. H.K. Nagaraj, sir.
शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः
A journey of 1,000 miles begin with a single step. We have Dr. H.K. Nagraj honoring us with the Professor B. Hanumaiah Oration, and his topic of today is My Journey in Robot-Assisted Urological Surgeries. But before he delivers the prestigious oration, may I now request Dr. Kalaivani, past president of the Surgical Society of Bangalore, to introduce Professor B. Hanumaiah, orator for today, Dr. H.K. Nagraj.
Good evening, ladies and gentlemen. It's indeed an honor to introduce Dr. H.K. Nagraj, with whom I am associated with for the last 16 years. I have been, we are colleagues in Ramaiah Medical College and Hospital, and sir has always been very kind, very enterprising, very encouraging, and above all, a person with very good heart. So let me just introduce Dr. H.K. Nagraj. Dr. H.K. Nagraj hails from Bangalore Rural District. He completed his MBBS in 1976, MS General Surgery in 1980 at Bangalore Medical College. He did his MCH Urology at KMC Manipal in 1987. He worked in the urology department at St. John's Medical College for 8 years. He then joined Ramaiah Medical College in 1989 and established the urology department. He was instrumental in starting MCH in Ramaiah Medical College in 2009. He popularized laparoscopic urology all over India. He has gone as examiner to several reputed institutions all over India. His publications are cited in urology textbooks. He is a recipient of several awards. Just to name a few, he is a gold medalist in ENT competition exam, Best Scientific Paper Award at National Annual Conference at USI Delhi 1983, Best Scientific Paper Award at an Annual Conference of Kerala Urological Society Association in 1985. He has received the Best Scientific Paper Award at Bangalore Surgical Society meeting 1988, and he has won all the Young Surgeons Award for the Millennium Gold Medal, if I'm right, sir. Most of them. Yeah, we can have a round of applause for that. He has won the Best Paper Award by International College of Surgeons, October 1990. He's a gold medal recipient for the Outstanding Research in Urology by the Bangalore Rotary International in 1997. A gold medal for the Outstanding Scientific Paper in Urology by the Bangalore Rotary International 1998. He has been an organizing secretary of 29th Annual Conference, Urological Society of India in 1996. He was invited for the teaching program at Rose Medical Center, Denver, USA in 1996. He has also received Aryabhatta Award in 2003, Kannada Rajyotsava Award in 2007, Outstanding Social Service in Medical by Red Cross Karnataka 2008. I have seen sir giving his checks for the patients who could not afford to pay their bill. I have witnessed this. He has received Scroll of Honor by Surgical Society of Bangalore in 2008, Doctor's Day Award in 2008 by the Indian Medical Association, Bangalore branch. He's a teacher par excellence. He was given this award by Dr. MGR University, Chennai in 2013. He has delivered several guest lectures, and he has also received the Nada Prabhu Kempegowda Award in 2016. Sir is always accompanied and been supported by Mrs. Shobha, who's his better half. Madam is here. Madam, thank you and welcome here. And sir's enterprising sons, Dr. Arjun, who's a urologist, he's here. Dr. Arjun. Please get up, Arjun. Dr. Jeevan. Dr. Mrs. Apurva, his daughter, and Mr. Kailash, his son-in-law. Arjun's wife, Dr. Vanita. She's not here, but she is also a part of this family. And we welcome all of you. Thank you.
Thank you, Dr. Kalaivani. May I request everyone to keep their mobiles on silent mode, please? Dr. H.K. Nagaraj, over to you, sir.
President-elect Professor Siddesh, the Honorable President of Surgical Society of Bangalore, Dr. Venkatachala, Honorable Secretary, Dr. Harish, the senior surgeons of the Surgical Society of Bangalore, dear friends. It is indeed a great pleasure, a great honor to present an oration on such a great man, a great teacher, a great inspirator. Unfortunately, I was not there when he was in the Bangalore Medical College. And my professor, Dr. Ashok Kumar, keep on telling about him. So I thank the Council of the Surgical Society for inviting me to talk on this topic. A few words about Professor Hanumaiah. It is customary, I have to tell. So Professor Hanumaiah was born in 1920 from Marapanapalya village, Nirmangala Taluk, Bangalore Rural District. He completed lower secondary examination at Magdi Town. He walked from his native village to Magdi Town to fulfill his desire of completing the lower secondary examination. He was encouraged by the government of Mysore to further his studies from 4th form till the completion of LMP, for which he was sanctioned full scholarship. In 1941, he secured first rank in LMP examination conducted by the Medical School of Mysore State. 1946, he received Freemason Golden Jubilee Prize from His Highness Sri Jaichamarajendra Vadiyer, the Maharaja of Mysore, for having secured first rank in MBBS in the University of Mysore in the final year for general proficiency. 1955, he passed FRCS in the first attempt. In 1955, on his return from England, he was appointed as resident medical officer at Victoria Hospital, Bangalore, and assistant professor of surgery, Bangalore Medical College, Bangalore. He also contributed a number of papers in the journal Surgery. 1958, he was promoted as the associate professor of surgery at Bangalore Medical College. He served as examiner for MBBS and MS degrees of Bangalore, Mysore, and Karnataka University. 1966, he was retransferred to Bangalore, where he became the postgraduate professor of surgery, Bangalore Medical College, and surgeon at Bowring and Lady Curzon Hospital. 1987, a Rajyotsava Award was conferred on him by the government of Karnataka. On 1st July 1990, Doctor's Day Award was also conferred on me by the Indian Medical Association, Bangalore. Now, coming to a brief introduction about a great man, I chose this topic basically because it is really simplifies a person, those who are involved in the laparoscopy work, how much of shoulder pain, back pain. So you must have experienced, especially as the age is catching up. It is very difficult to do a surgery for 3 to 4 hours, especially in urology. When we are doing a radical prostatectomy, we take about 2.5 to 3 hours, and all the time standing like this. So with the advent of the robotics, it become very easy. I can do 3 operations, robotic radical prostatectomies in a day without any strain on my back or on my shoulders. Way back in 1996, I got the passion for laparoscopy work when I went to Montreal for our urology conference. I was inspired by looking at the work, how they were doing, and especially children, where there is no cutting, only a few scars. So I wanted to pick up this knowledge Then unfortunately, in the same year in December, I had a conference. I bestowed on me to conduct a national conference. So I took this theme, laparoscopy neurology workshop, and it is the first time in the country a laparoscopy neurology was conducted, and many people came up from abroad. And then when they operated, when I was personally seeing, I thought I'm not going to pick it up because they were struggling, taking 4 hours, 5 hours to do a surgery. I thought I may not do this. But my passion was pushing me that I should pick up this. I got the videos from different people. Then I saw the YouTubes, then started doing myself slowly and steadily. We started that, and we were the first to start in Bangalore and popularize the laparoscopy urology work, especially in infants below 1 year of age, and there is hydronephrosis. It's very difficult. It's very painful to me to cut open and do a pyeloplasty on that child. So whereas laparoscopically, so beautifully we can do it with small scars, and next day the patient is going to have food. There is minimal of the ileus on the child, and excellent results, and the infection rate is so low because the exposure, wound exposure to the environment is very limited. So we have the highest number of infant pyeloplasties, which we published in the journal. I wanted to publish in Indian journals because I don't want to publish in international journals, give credit to somebody else. And fortunately, this is quoted all over the world, the large number. So many other things I'm going to tell. So this is the beauty of laparoscopy. I practiced it. Then when 2009 onwards, the robots started coming, the popularizing, and then few robots came to, the first one was in Delhi. Then I requested our management to buy a robot, but it was so expensive, so they delayed it. Then finally, they got it in 2020. My age was catching up, so I'm forced to retire. So by the time I retired, I completed some of the cases which I was enthusiastic to do and learn. And thank God I learned it by the time I retired. Now I retired from there. Now I didn't want to go for private practice. I want to be in teaching for some more years. So fortunately, the call came from the Saptagiri Medical College. So I joined there, and we are going to start MCH urology program. I might do the work there for 5 years and then get out of this job. So this is how I wanted to start. Second thing is, my main reason for developing a passion for all these new things is, we are in a medical college. So we are teachers. Whatever we do, these students are going to pick up. If I don't do a major complicated operation, the student doesn't develop a confidence. So if a teacher cannot give confidence to a student, he should not stay as a teacher. Rather, let him go out and practice. He can make a lot of money. This is my contention. So I tell my colleagues also, if you cannot concentrate here, please leave, go. You are most welcome to do practice outside and make money. But when you are in a medical college, dedicate yourself. You are a great teacher. So this is how I came up, and I also try to give the advice. So unfortunately, I was forced to resign on July 31st. So I have no regrets, because I have served the institution for 32 years with passion, and I picked up a lot of things. I did a lot of service to my poor patients. So the main purpose of going to a medical college again is to serve the poor, which I may not be able to do if I go to Aster or a Manipal hospital. So this is my number, 64 cases. Where is it? Oh, it's coming there, sorry. 64 cases, because they installed at the time of the COVID wave, the first COVID wave, and then in January they installed. So by the time they do that, and I also get acquainted, so it took time, and May 2020 started doing it, and A mentor had come, and the first case I did myself. Then the mentor said, "Sir, you don't need a mentor." I said, no, you have to come for at least 2-3 cases. So this is how we did. VBF repair we did, pyeloplasties, pyelolithotomy, partial nephrectomy, radical nephrectomy, radical cystectomies. Radical cystectomy, I can finish in 1.5 hours in robotically, which is so simple to do it. And then radical prostatectomies, we take about 2 to 2.5 hours. Adrenalectomies, I'm going to show some of the videos, ureteric reimplantations. Cholecystectomy, I did it not because I wanted to pick up a cholecystectomy, how I do it robotically, but I wanted to show to our surgical colleagues that, see, for the effective utilization of the robot, you also start doing it so that the management doesn't, because of my pressure, they got it. If everybody uses it, they'll be happy. Otherwise, they will keep on questioning me. Where is your number? What happened? Like that. So Kalaivani was there. And then Shrikar Pai, I asked him to do it myself. It was my case. I posted, I called him. He was very enthusiastic guy. So he did it and he was thrilled. Unfortunately, the another 50,000 is added to the bill. So they may not be able to do much. Now I'm going to show some of the videos, which is short videos edited. So this is one patient who had about 20 stones because of the congenital pelvic junction obstruction. And so he is around 20 years. So robotically, we corrected the obstruction. We removed all the stones. So this is, see, the robotic instruments are very traumatic. So there are some atraumatic instruments which we don't have it. They're more expensive. But so that's why we avoid as far as possible touching the tissues which we are operating. So that's why I've taken that sling. And then the fourth arm is beautiful. It holds it, and without any shake, it holds it. And it's very easy. See, we are dissecting the pelvis, and we are opening the pelvic junction. See, the beauty of the robot is there is not much of mobility like our hand movement, hand shakes. So that is one advantage. Probably the aged people, when there is tremors appears, they can still use robot because the tremors is masked by the computer. So this is a huge stone this patient had. I think there were 2 stones. So I put finally a gallbladder holding forceps, 10 mm forceps, and pulled out that stone. It was not coming out otherwise. So there were 2 big stones were there. So this is the disadvantage of a robot. If you want to change the arm, it takes time. At least 2 to 3 minutes is lost. So finally we removed the stones, and then we put a double J stand. The tactile sensation is very limited in robotic surgeries. At least in laparoscopy, we will be able to feel something coming back to us. But here it's not there. So majority of our pyeloplasties, we use this V-lock sutures, which are very good, 40 V-lock sutures, self-retaining, so that the urine leak and fibrosis and the complications of a stenosis of at the pelvic junction are very limited, restricted. See how the fourth arm, which is holding, constantly it is lifting up and showing us all the time, which in a laparoscopy, the assistant may not be able to show. He has got a strain on him, so he will leave it. Once again, we have to catch it. This is almost completion of the closure. It's very easy to suture. Only fingers movement will be there. We keep moving. Unlike in a laparoscopy, where a suture is strained unless where the person is experienced. Okay, that's it about laparoscopic pyelolithotomy. This is one patient who had an adrenal mass. So this boy, about 28-year-old fellow, when he was walking, he used to fall off. So because of the weakness of the lower limbs. So when somebody checked it, potassium was very low, 2.3 like that, it used to come. And he also had hypertension. So we evaluated, we found an adenoma, and then the aldosterone was very high. So it is a constant disease. Adenoma is secreting this one. So here, we not necessary to remove the whole adrenal gland, only the adenoma part we can remove it. So this is what I'm going to show here in this picture. Can you play this? Okay, explain, thank you. See this spleno-renal ligament, spleno-colic ligament. So both the ligaments should be cut so that the colon will drop out. So that is the spleno-renal ligament which we are cutting. The advantage in a robot is on the left side, there is a bipolar cautery. So immediate cauterization is very easy, bipolar. And then right side monopolar is there. So the same technique I was using without seeing the robot, in all my cases in laparoscopy, I always used to carry a bipolar in the left hand. And the Indian make bipolars have got a very good grip. Jaws are very good. So you can catch them, good grip you get. Unlike the imported bipolars, the grip is not there, it slips off. So after pushing the colon, you see this one pancreas here. You can see the pancreas here. And then we straight away go and identify the renal vein. You see the renal vein here. Then we identify the adrenal vein. If we are doing it for a pheochromocytoma, we immediately clip it most of the times. We rarely do a partial adrenalectomy because the hypertension crisis may be there, that's why. So, but here I dissected the adrenal vein, kept it, and this is a healthy adrenal gland which you are seeing here. The whole thing is a healthy adrenal gland. You see the adenoma which is popping there inside, that one. So that was stuck to the lowermost part of the adrenal gland. So we mobilized only that part. And the fourth arm is beautiful. It picks it up and lifts it up for us. See, this type of manipulations we can do if it is not a pheochromocytoma. If it is a pheochromocytoma, there is some risk involved. The crisis can occur. So we rarely go for that. And instead of clamping the adrenal vein, I traced the pedicle. So this is the pedicle, which was feeding that adenoma. Then we clipped it. So now we're cutting the pedicle. So all this type of the precise work, you might call it a gimmicks. This is very easy if you have a robot. Unfortunately, the cost is hindering us to use the robot. The new companies are coming out with the robots. Maybe it will become cheaper if it is between 1 to 2 CR. So everybody can have this and can give a quality work to the patient. So that is the final stump. We put a clip. Hemlock clips are very handy in all this clamping the pedicles. Takes less time, more secure. So that is the fourth arm which is holding all the time for us. Now I'm going to the other operative technique, a partial nephrectomy, which is a very important procedure in urology, because the days have gone where we used to do a radical nephrectomy for any small renal masses, which are less than 5 to 6 centimeters. We should not do a radical nephrectomies. It is almost a crime like nowadays. So we have to do a partial nephrectomy. So here the colon is pushed, mobilized. The artery and vein are mobilized so that we can clip it. Bulldogs we can put temporarily, we can clip. We are mobilizing the artery. And we loop the artery and vein to keep it ready whenever we need it for putting the bulldog clamps. So that is the bipolar which I was telling, the Indian make bipolar, which is costing less than 5,000 rupees. It is very handy, I'll tell you. So here my assistant will be helping using a bipolar. In case any bleeders, he keeps burning it. He keeps giving tractions. So after we secure the vessels, we just loop them and keep it. Then we open the gyrotous fascia. So the olden concept of, the don't go close to the tumor and all is gone, because they have done studies. They have taken the biopsies from the gyrotous fascia or that close to the tumor. So no recurrences is same. So nowadays it is almost like enucleation technique. Go close to the tumor. And now we are going to clip. If the tumor is on the left side, it is better if you clip only the renal artery. Renal vein can be left open so that the ischemia to the kidney will be less. Whereas on the right side, we have to clip both artery and vein, because the IVC flow is more through the vein and there will be back bleeding. So this is how we can core out and remove the tumor. So then we take a V-lock sutures and close in 2 layers. This is the inner layer is hemostatic suture. All the small artery and veins are blocked. Even the calyceal system which is open can be closed with this continuous running suture. And this is easier and quicker in robotic surgeries than in a laparoscopy. So we just put a hemlock clip and slide it because it is very difficult to tie. It will cut through the parenchyma. So this is better, and this is what we call it a rhinorrhaphy, bringing the cortex together. It is called rhinorrhaphy. Jerk. So that is the end, and we release the artery. So then look whether there's any bleeding is there or not. We can take over sutures over that if there's any bleeding. We go to the next one. So this is radical prostatectomy. Earlier we used to believe that the prostate cancer is not that common in India, but it is commonly seen. We were not looking for that properly. We were not doing prostate-specific antigens in all patients. At least we should do PSA in the patients who come with urinary symptoms to the clinics. So that was not happening. That's why when I was working at Hanumaiah Hospital, my unit used to pick up a lot of CA prostate. The other people are not seeing a lot of CA prostates. Basically, we were looking for that. So we had a huge number of laparoscopic. So first we dissect the rectal pouch. Seminal vesicles are dissected out so that it is easy when we go anteriorly. So this is, we are dissecting in between the rectum and the bladder. After that, we push the bladder down. So we go into the space of ridges and put the bladder down. So you see the pubic bone there. This is the pubic bone. So that is the prostate which you are seeing. Whitish one is the prostate. And then dorsal venous complex has to be sutured. Deep dorsal vein will be there. This is the commonest problem where there is a lot of bleeding. Okay, got it. That is the dorsal venous complex which you are trying. So then we take a suture. This is the commonest place of bleeding. Earlier, when we were doing the open prostatectomy, we used to give invariably 2 to 3 bottles of blood. Now, we hardly give, very rarely, we are giving blood. Only blood grouping is done and kept, that's all. So the seminal vesicles are pulled out. Afterwards, we open the bladder neck and pull out the seminal vesicles, then dissect out the whole of the urethra, cut the proximal urethra. So this is where the fourth arm helps. It lifts up the prostate so that we can go down denonumerous fascia, we can dissect and go close to the prostate so that the rectum is not injured. So now we are going into the apex of the prostate. You see the catheter already there. The rectourethralis muscle has to be cut. You see, only that part is holding on. And majority of the times, the Indian patients which we see will have a lot of inflammation. So it is not that easy like the West and Europe, where you just peel it. The tissues will go. Here we have to cut it. We have to use cautery. And then we try to preserve both sides neurovascular bundles so that erectile dysfunction will be restricted, will be very less. even though the Indian population doesn't complain to us, but we try attempt to keep the neurovascular bundle intact. I'm going to show afterwards the neurovascular bundles which we have preserved. So that is the proximal urethra with the catheter we are seeing. That is a neurovascular bundle. Both sides like pillars will be there. So later on we suture it. The bladder neck is sutured back to the proximal urethra. And my technique of doing this anastomosis is, I try to preserve the bladder neck. I don't cut through the bladder neck. I try to preserve all the muscles of the bladder neck. The bladder neck will be very narrow so that the continence is very good. Within 10 to 15 days, the patient is continent. So I was talking to several people, those who are coming from abroad. So they were telling that you preserve neurovascular bundle, continence will come. But it is not true. Bladder neck has to be preserved. So we are doing a nerve dissection. You see the operator nerve here. And you see the external iliac artery, internal iliac vein, external iliac vein. So all the lymph nodes will be dissected out. The last video I'm going to show is about the ureteric reimplantation. This lady who underwent a hysterectomy had a ureteric injury, and then she came to us after a gap of 6 months. Patient had a lot of pain, vomiting sensation because of the hydronephrosis. So the detection was late. So we corrected this through robotic. So we are dissecting out the ureter. You see the ureter there. Peristaltic wave you are seeing, and dissecting down to the bladder. Doing pelvic surgery by using a robot, it's more comforting, less strain to the surgeon. So that's the great advantage of robot, except the cost factor. To minimize the handling, we use these techniques because the robot arms are really traumatic. I think you all know, if anybody who is using in a general surgery, where now I'm cutting the strictured part, spatulating, in case we have touched the bowel by the robotic arm, it can get perforated, it can get injured. So that is the disadvantage of robot instruments. So nowadays they have come out with vascular instruments. So it's a very instrument is going to be expensive, minimum 2 lakhs, one hand is going to cost. So then the bladder is filled, and we are going to do an anastomosis to the dome of the urinary bladder. So we have dissected the detrusor muscles, and don't open the mucosa till we finish off one layer. So we close one layer. Away from the surgeon, we should close first. It's very easy towards the surgeon to close later on. We take continuous suturing. It's not necessary interrupted suturing to be done. So later on, we put a stent So now we open the bladder. So that when the bladder is distended, it is very easy to suture. If you get used to the robots after at least about 10 cases, the time will come down, the speed will increase. So we can cut more than 50% of the time comparing to the open surgeries. And the important thing is the surgeon strain will come down. So you need not go home and take rest after any major surgeries. You'll be still feel lively. Okay, I'm trying to repatronize, reduce the raw area as much as possible. So this can happen, when you take a V-lock suture, the assistant need not hold. Of course, in a robot, there is one more arm which can hold it. So I think this is the end of it. So that's all I used to say about my experience in robotic surgeries. I really enjoyed operating in robotically because the strain on me was very less, very comforting, wonderful suturing we can do, and the end results are excellent. So thank you very much for the patient hearing.
Thank you, Dr. H.K. Nagaraj, for a wonderful and illustration as well as lucid videos about your journey. Sometimes I wonder the journey itself is the reward that we deserve more than the destination. Thank you, sir. We'll begin with the felicitation of Professor B. Hanumaiah, orator, Dr. H.K. Nagaraj. May I also request Dr. Ramdev, sir, to join with the felicitation of Professor B. Hanumaiah, orator 2021, Dr. H.K. Nagaraj. And I would request the family members of Professor B. Hanumaiah, Dr. Sharachandra Balachandra, if they are around, to join the office bearers of Surgical Society of Bangalore to felicitate Dr. H.K. Nagaraj. gentlemen, a big round of applause for Dr. H.K. Nagaraj, the orator for the Professor B. Hanumaiah Oration 2021. Thank you, sirs. Thank you, sir. Dr. H.K. Nagaraj has also shown us that age is not a barrier in the pursuit of excellence. We move on to the second prestigious oration. We have the Professor M. Adikeshavalu oration, and we all know that the road to success is always under construction, filled with risks and with rewards as well. We have Dr. Rajshekhar Reddy, chosen as the orator for the Professor M. Adikeshavalu Oration 2021, and he'll be speaking on the topic of his choice, risk appetite of surgeons. But before his oration, I would like to invite Dr. Venkatesh KL, past Secretary of Surgical Society of Bangalore, to introduce Professor M. Adikeshavalu, orator of today. Dr. Venkatesh, sir.
Good evening, all. Actually speaking, today orators doesn't need introduction. All of us know them very well since long time. Still, for formality's sake, I'll be introducing my close friend, Dr. Rajshekhar Reddy. All of you know, he is a consultant thoracic surgeon at Sagar Hospital. Right now, he is the director of Clinical Skills Center. We did on the first day, we did as usual, annually we do one-day skill training program for all the surgery postgraduates. So he is right now the director of Bangalore Medical College Development Trust and Alumni Association. And I would like to invite the director and the Lakshman sir. We have one more skill center in BMC where we have all this bronchoscopy, endoscopy, colonoscopy, all this PIC lines, all that. So Dr. Sandhya is in charge of that. Those from Hanumaiah anesthesia, she is in charge. So BMC has got 2 skill center. Please utilize that. Rajshekhar Reddy sir he was visiting consultant as SDS Sanatorium, Tuberculosis Research Center and Rajiv Gandhi Institute of Chest Diseases from 2012 to June 2017. He was associate professor of thoracic surgery at Devarajaras Medical College, Kola from 2004 to 2009. His qualifications are too many: undergraduation, post-graduation, FRCS, FEIS, FICS, FISES. He is a member of so many associations like our Association of Medical Consultants India, Cardiothoracic Surgery Network, Indian Society of Cardiovascular and Thoracic Surgeons, Indian Chest Society, life member, Indian Medical Association, Surgical Society are our privileged member, Indian Red Cross Society, life member. And he is editorial to so many journals. Right now, he is on editorial board member of Indian Journal of Thoracic and Cardiovascular Surgery from 2016, the Springer being the publishers. He has been a reviewer for so many journals like European Journal of Cardiothoracic Surgery, Interactive Cardiovascular Thoracic Surgery, Indian Journal of Surgical Oncology, Asian Cardiovascular and Thoracic Annals. And he was awarded the Best Reviewer Award for the year 2017 for the IJTCS at the annual IACTS Con 2018 held at Visakhapatnam. And he has been giving orations. He was the orator for 2017 for the prestigious Professor Godrej S. Karai oration during the annual meeting of Indian Association of Cardiovascular and Thoracic Surgeons in 2017 in Bangalore. He is a faculty chairperson organized, and he's been organizing so many CSEPs, and he's actively involved in so many city, state, and national level meetings and conferences. And he is into this emergency care life support. It's called Jiva Raksha. And he does a course affiliated to RGHS. And he is one of the core members involved from beginning, and trustee of Jiva Raksha Trust established to spread the awareness and universal reach of the project, which is called Jiva Raksha. And I have 4 papers of his publications. I've been given only 5 minutes. and he has published so many national and international journals. He's been blessed with two children, Dhruv and Janavi, to Rita Rajshekar Reddy. She's also a teacher. Doctor means teacher. So both are teachers and they are teaching the students. We're all here to learn from him. And Dhruv is doing arts, son. Daughter is doing 9th standard. Bless you, sir. Thank you. It's your time, sir.
Ladies and gentlemen, presenting the Professor M. Adikeshlu Orator 2021, Dr. Rajshekar Reddy.
Good evening, Professor Siddesh, President-elect ASI, Dr. Venkatachala, our own President. Very humble student way back in 1995, 96, 97, attending the same CSEP and the Orations, and then passed out with major benefit from the CSEP and all the teachers teaching. 2 decades later, to occupy the same chair and conduct the same CSEP, needless to say, present from morning till evening, I learned more than any student in 2017. And I thank all my friends and teachers once again for this opportunity. Today, if I'm standing here to deliver this prestigious oration, is because of all your help and support. Professor where he completed his FRCS and then moved to Mayo Clinic in United States. In our official surgical society information, we have a special interest on intestinal obstruction. But when I was speaking to his students from the Bangalore Medical College Alumni Association, where I'm actively involved, they also said his great work in peptic ulcer, his work on vagotomy GJ, handwritten research papers still preserved in Mayo Clinic. I tried my best to get a photograph of it. I could not. Came back to India in 1994 and joined Victoria Hospital in 1956. He became the first Dean of Bangalore Medical College, which post was called principal earlier to it. And I've changed my slides, but it's same. 1960 and 62, he was the Dean of Bangalore Medical College. Retired from Bangalore Medical College in 1967, but continued to practice in CSI Hospital. When I spoke to the students from Bangalore Medical College Association, he is a teacher par excellence, no doubt. Some of them described him as a Dean in the field of surgery. Some of them said he's a master surgeon. His teaching classes used to be overflowing at any given time. Usually he takes teaching, I believe, in the evening hours, and students used to be overflowing. And his art of correlating symptoms, clinical signs, coming to a diagnosis and management plan is something they describe, not replaced by another teacher so far. Unfortunately, we lost him in 1973 for CS stomach. I'm here to share my decision making, my thoughts, how I shifted from major part of my work in thoracotomy to major part as I do today into thoracoscopy. I'm not here to criticize any individual or organization. If you Google risk appetite, it describes as level of risk that an individual or an organization is willing to take while pursuing certain objectives before you take any action to avoid major risk or a disaster. Essentially, it means to say, you know the risk involved, you know when to take action before you pursue it, meaning to say it's a calculated risk, planned risk, knowingly well when to ask for help and when to call it a stop. If you Google from PubMed, there are several articles as to how the risk appetite of a surgeon changes from the time of his training to the risk factors that affect his risk-taking ability. Obviously, the risk, what is acceptable to me is different from the other person, and obviously different from patient to patient. Same risk-taking ability is different for me today. A 6 centimeter tumor, I would love to do thoracoscopically today. I would have done thoracotomy 10 years back. That we have to keep in mind. I looked at thoracoscopy, not just in India, but across the globe. This is the general scenario from early 2000, late 90s and early 2000 is when the laparoscopy really kicked in and all the laparoscopic surgeons started using it. There were many surgeons doing both laparoscopy and thoracoscopy work at the same time. So they shifted from thoracotomy to thoracoscopy. If they look at the literature, large majority of surgeries like lobectomy, pneumonectomy for lung cancer used to happen in the Western society. From early 2000 to 2008-10, all of them used to be thoracotomy, meaning to say, we were trying to adopt the principles of laparoscopy into thoracoscopy in terms of 3 ports, each port at a handbreadth gap. And if you remember, chest is a rigid cavity and you cannot insufflate it, distend it with CO2 insufflation. It's a different ball game in the chest. And all the insufflators of laparoscopy are kept at 12 millimeters of pressure. And we quickly learned at that pressure, it's a tension pneumothorax and we cannot use it. So we learned to keep it at 6 millimeters of pressure. But we have a peculiar problem in India. Electricity goes, generator comes on, your insufflator automatically sets at 12 millimeters, and then you relearn to reset it at 6 millimeters. So the journey went on. In those early years, endostaplers availability was difficult. Energy devices were not so easily available. Monitor were not HD quality and small. As a result, most of the work in that time, this is a classical thoracotomy position. Thoracotomy, you stand at the back of the patient. Please keep this in mind. This easy to understand what I say before. This is the only surgery that we do for sympathectomy done in the supine position because you need to do bilateral sympathectomy. So large majority of the procedure like sympathectomy for hyperhidrosis, diagnostic thoracoscopy in a patient with CA colon turned out to be tuberculosis, diagnostic thoracoscopy in a patient with recurrent effusion, which turned out to be mesothelioma, who was on ATT. Diagnostic thoracoscopy in this patient turned out to be a cat scratch disease. All these procedures, I had 100% success. But when it comes to doing a difficult case like a lobectomy, pneumonectomy, bronchoplasty, I used to start all cases thoracoscopically, half an hour, 1 hour down the line. Most of them used to get converted. So conversion rate was more than 50% up to 2010. And at the end of thoracoscopy, even if you are successful in doing a lobectomy or a pneumonectomy, we have to do a 3 to 5 centimeter incision to take out the specimen. That was a common scenario. As I said earlier, we stand at the back of the patient, conventional thoracotomy. And if you put an utility incision at the back of the paraspinal region, intercostal spaces are very narrow there, and retrieving the specimen was almost impossible. So we learned putting a para-sternal anterior approach, incision, the widest part of the intercostal space anteriorly, so you can deliver the specimen quickly. At this time, we were thinking, again, on the conferences, seminars, why can't we use this utility incision to begin with instead of doing it at the end? That's how the concept of single port thoracoscopy or modified single port thoracoscopy came. By this time, we had a good support from the anesthetists who used to put a double lumen tube and single lung anesthesia so that the lung collapses. Energy sources were plentifully available. Staff were more trained because of our exposure. I used to conduct wet labs. I went to Ethicon lab in Chennai to learn hands-on stapless technique. We went to Singapore to wet lab, animal lab session. And as a result, our understanding and skills improved. Many surgeons do a single port, and we in general do a modified single port plus a camera port. We were using the CO2 to insufflate or collapse the lung to begin with, and once you do an utility incision, there was no need for CO2. And obviously, many more procedures could be done thoracoscopically. In this process, where you stand at the back of the patient to do a conventional thoracotomy, Richard from Edinburgh came out as an Edinburgh approach, do a posterior thoracotomy with an utility incision, and he suggested take out a segment of the rib if you find it difficult to deliver the specimen. But in general, we don't agree with it, because once you cut the rib and take out, the benefits of thoracoscopy is gone. So the McCain, which was then modified by the Hansen from the United States, anterior thoracoscopy, where you stand in front of the patient. Obviously, the whole anatomy is different because you need to work on the pulmonary vessels which come directly from the chambers of the heart. difficult to manipulate that was the main reason, apprehension and fear of bleed from the pulmonary vessel. Within 2-3 minutes, patient will exsanguinate. In the posterior approach, shove a swab and a stick to pressure on the bleeder was also very difficult. In the anterior approach with a wide intercostal space, it is much easier. So we all adopted anterior approach, and we went ahead to do, this is the thoracotomy incision. This is where you put the anterior incision. If you connect the two is the posterior thoracotomy incision. This is the posterior approach, utility incision. So it was difficult to decide whether to go anterior or not, and then reorientation of the anatomy. And then we quickly learned and started doing regular procedures. All these procedures that are listed here, plus what was done earlier, like decortication in an early empyema, even in a reasonably established empyema with a thick cortex, it was successful. Evacuation of an infected clotted hemothorax, bullectomy, wedge excision of a lung nodule, pericardial window, thymectomy in myasthenia gravis, all these things could be done, almost 100% success. But again, when you think of doing a lobectomy, pneumonectomy, dissection around the hilum, especially in the Indian setting, most of patients will have a past history of TB or an infection where there is a dense adhesions, and dissection around the hilum was very difficult. To our benefit, Ethicon came out with a stapler with a curved tip, golden curved tip, which makes life so easy to go around those thin pulmonary vessels. Unlike the other vessels, pulmonary vessels don't have the adventitia, tunica media, etc. They are very thin vessels, easy to tear, and they just bleed within 2-3 minutes. With all those advantages, this was a bullectomy for a pneumothorax. This cases of empyema, we are using conventional instruments through the anterior incision to recover the MUP. This was a thymectomy, about 4.5 centimeter thymoma, calcified thymoma in a myasthenia patient. At that stage, a tumor of this size was still a case for thoracotomy. But if you give the same case to me, I would be happy to try thoracoscopy. We came from around 2005 to 2000, as on today, we all adopt anterior thoracoscopy, 3 to 5 centimeter incision in the parasternal region in the 5th intercostal space. In India, and I use a modified with a 3 centimeter incision and a separate camera port, simply because most hospitals that I visit have a single tower with an HD monitor. During our thoracoscopy workshop, one of the Korean surgeon was presenting his work, and it was so beautiful to see and appreciate. One of our Indian surgeons stood and asked, in a single port, where does the cameraman stand? Where is the space for cameraman to stand? He said he stands on the opposite side of the patient, posteriorly. If he stands there and holds the camera at the upper part of the single port, where does he see the monitor? For a few seconds, he didn't understand the question, and the moderator explained him again. Then he said, oh, no, I work in Samsung Hospital. Samsung Hospital is the pioneer of television manufacturer. On 3 sides of the OT, they, I believe, have the 50-60 inch HD monitors. Visualization is not a problem. So the amount of equipment and support and the energy source, the staplers that needed to do a single port, classical single port, to do all the work. There are few surgeons who do robotic single port, any kind of thoracic work, because they have all that support. Unfortunately, we don't have, so we resort to modified single port with a separate camera port without interfering with the cameraman. As on today, we don't use the CO2 insufflator at all, so we don't worry about the electricity is on or generator is on, so the pressure is not a problem. Swab on a stick, which is the most scary part for us, is the bleeding from the pulmonary vessels. Swab on a stick is kept ready at any given point of time. If there is a bleed, the earlier days, we were used to sweat to convert as soon as possible. By then, we used to lose at least a liter of blood. Now we have a swab on a stick ready. Even if it's a pulmonary artery is completely or partly cut, we keep a swab on a stick, wait for 5 minutes, ask the anesthetist to get the blood products. At the end of 5 minutes, what appears to be a torrential bleed requiring a conversion will come down, requiring a little suturing, or you can manage them thoracoscopically and get going as on today. That learning curve was necessary for us because you cannot reproduce or copy the laparoscopy techniques into thoracoscopy. As on today, any procedure that can be done by thoracotomy can be done thoracoscopically. I'll show you a few examples. This was a 27-year-old gentleman. April, COVID, you can see the ground glass densities. And then week after discharge, he comes with left pneumothorax, treated at the other hospital with a chest drain. At the same time, you can see two central lesions like bullae. Those are called pneumatoceles. Week after discharge, progressive breathlessness. You can see a big pneumatocele on the right side and a partly resolved pneumothorax on the left side. I was not sure whether this is a pneumatoceele or an encysted pneumothorax. Went ahead and put a pigtail catheter, but it did not reduce. Repeat CT 2 days later, it was persisting and he was stuck to 6 liters of oxygen. So we went ahead with thoracoscopy. You can see the conventional instruments being used. You can see the pneumatoceele occupying the entire chest, and at the apex is a small collapsed lung. We could excise this pneumatoceele in this post-COVID patient with fibrosed lung thoracoscopically. That's the collapsed lung, that's all. And he did well. Similarly, I have one more patient in the month of May, mid-May, COVID pneumonia. Almost 2 months later, he goes becoming septic, febrile, rise total count, infected pneumatoceele in the right lung, which was again excised thoracoscopically. He did successfully, went home within a week. So to look, benefits of thoracoscopy in these patients is enormous, and you cannot count on that. This was a large leiomyoma occupying almost from the apex of the chest to almost up to the diaphragm. We could excise it thoracoscopically. This was a patient denture stuck in the mid-esophagus for about 3 weeks, removed thoracoscopically. This was a case of carcinoid in the right bronchus intermedius requiring middle and lower lobectomy. This is a bronchoscopic view. Bronchoplasty. This was an aspergilloma, again thoracoscopic. This was a completely destroyed left lung requiring a completion pneumonectomy. Again, thoracoscopically, I can do it. We have successfully. This was a case of ruptured liver hydrated into the pleural cavity. That video shows hydrated data cysts into the ICD bag. This poster, we have presented all these cases in various surgical society meetings. Successful outcome. As I speak today, there are many surgeons across the globe doing pure robotic thoracoscopy work. There are patients who, one surgeon from China said, why put incision on the chest? I'll put it in the subxiphoid region. Fine. Somebody said, I will put it in the cervical region. There's a limit to what surgeries you can do from a different approach, but somewhere you have to put the incision to access the organs. And there are good number of advances happening as we speak. This is not the last slide of my presentation. I have at least six more slides, which is very important for most of us. For this presentation so far, if you have slept thinking that I don't do thoracoscopy, why should I listen? Doesn't matter. Please wake up for the next slides. These are my thoracic surgery gurus, Raman Deshpande and Sanjay Sharma from Tata Memorial Hospital. These are all the teachers who taught me what to do, how to do, when to do, except this gentleman who taught, we keep saying don't do in many specialties. Like when you're doing esophagectomy, mobilizing stomach as a conduit, don't damage gastroepiploic circuit. If it gets damaged and if you still replace, what happens? Those kind of don't do's, this great teacher taught me. Gentlemen, I took my thoughts to add these 6 slides because healthcare delivery is being radically changed. Government has a duty and obligation to take the super specialty healthcare to the doorstep. Major hospitals are swallowing the smaller hospitals. Young entrepreneurs in their 20s and 30s with several millions of dollars, crores of rupees in their hand want to experiment any other form of healthcare delivery other than the conventional patient coming to you and you deciding to operate or not. These are tough changes, tough times, and there are going to be radical changes in the future. The only way we can decide this is what is beneficial to the patient and this is what I do, only when you have the knowledge, where is the money, why the rich keep getting richer, how can I achieve that financial freedom? Pardon me if you don't like these slides, but it has taken at least a couple of years, couple of paid mentorship programs, several articles, podcasts, to put this material into 5 slides in a way I can understand, then I thought I will share it. Because you don't get this information on Google or anywhere else, because it is hard to find. Financial freedom is for you to continue to enjoy the current lifestyle. One may require 1 lakh, other may require 10 lakhs, even not going to work. Meaning to say that money should come to your account month on month, even if you are on a leave on Caribbean cruise. we fail to understand where is the cash, what is the cash flow quadrant or money flow quadrant. Quadrant is basically left and right. Left side is the employed. For the simplicity, I have put it. It's basically like our nurses, ayahs, or government employees who work on a stipulated time. What to do is decided by his boss, but 100% done by you. If you want more money, you need to do second job and third job. There was a pension schemes which was not there now. We have moved from employed to self-employed. Once you become qualified professional and labeled as a consultant, where you have a special skill, you can decide working hours. You definitely earn little more than those employed, but you still have to work. Money doesn't come if you apply leave. Financial freedom is not possible for us because you have to work to earn the money to pay the bills. On the right side is the business or entrepreneurs. They definitely need a burning idea that's going to change the lifestyle of large majority of the population across the globe. Then you need the capital, license, etc., to go ahead and do the business. Then comes the investors who tag on to the entrepreneurs and make money. The well-known person who made money through the investment is Warren Buffett and Charlie Munger from United States. We all know he was the richest man on the earth for several decades till the Tesla and Amazon came into the picture. In India, when you speak about markets, it's largely talked about person is Rakesh Jhunjhunwala. I should appreciate because at least people know what is investing, what is market through him. But there are many, many, many hidden gems in our society. One of them is Radhakishan Damani, fourth richest man in India with $29 billion worth assets, roughly translating to 21 lakh crores. Rakesh Jhunjhunwala is only 42,000 crores. Rakesh Jhunjhunwala is starting the airline called Akasha today, but this man, Damani, started DMart, if you have ever been, listed in the market as Avenue Supermarket, started this long ago, and is quite successful there. Why am I telling this? Because to earn money in the left quadrant, you have to go to work and earn. More you pay. Tax is usually 30% plus 3% or more. After you have to pay the tax, then the remaining money you have to spend, and when you spend that money, again you pay the GST. On the left side, once you are successful in doing something in Bangalore city, you can multiply it in multiple cities across the globe. Once it is successful, some manager will look into it. You can pursue another course, see another business. So it is scalable, multipliable. Like we are doing one operation, they can do thousands and lakhs of operations at the same time. That compounding is possible. They are treated as wealth creators because they create the job. They are awarded with a tax of capital gains. Whatever they spend is shown as a cost of doing business. The remaining money you pay the tax in capital gains, maximum 15%. To do anything, you need to know the law of the land. I was also very happy to know that 95% of the people are on the left quadrant. I was also happy as a democratic citizen. What more do you want? Until I was shown this fact. Gentlemen, if you don't believe, please go home and do the research. Less than 10% of the people hold more than 90% of the cash, not just in India, anywhere, even in Pakistan, Afghanistan, Europe, Middle East, America, everywhere. Governments cannot scare them because they are the job creators. Government will respect them and do whatever benefits they need. You don't have to be scared because all of us, all the millionaires, billionaires have started with a salary from the left quadrant. In your journey as a salaried person, you have to ask yourself, how long can I do it? When can I do what I want to do? At the age of 60 or 70, if you still want to learn a new technique, go ahead and learn it, enjoy it. But if you're still doing the job for the sake of paying the bills, I pity myself if I do so. Because it's a choice to shift from left to right quadrant. It comes out of questioning yourself, what am I doing? It comes out of dedication, discipline, and learning from the masters, not from your friends and neighbors or not me. You have to learn it from the masters who have already done it, what I mean to say. Not handing over your money from the savings bank to a fund manager and expect him to multiply your wealth, because that fund manager is working for a salary to pay his bills. He has not created a wealth for himself. You have to be responsible for your money. You have to create that wealth for yourself. You don't blame on anyone else. You have to learn it by the failures, and that fear of failure should not stop you from pursuing to succeed. We all have learned laparoscopy or thoracoscopy because you want to learn. I don't know what stops us from there on to pursue the rest in the life. Only way is to learn. Thank you very much for your patient hearing.
Thank you, Dr. Rajshekhar Reddy, for a wonderful Professor M. Adikeshwulu oration. Another big round of applause, ladies and gentlemen, while we begin the felicitation for Dr. Rajshekhar Reddy. May I invite Dr. Siddesh, Dr. Jairaj, family member of Professor M. Adikeshwulu, to join with the felicitation along with the office bearers of Surgical Society of Bangalore. Ladies and gentlemen, Professor M. Adikeshwulu, orator of 2021, Dr. Rajshekhar Reddy. I think Dr. Rajshekhar has kept everybody wondering. There is always risk in anything we do, but I think he has told us that risk needs to be managed and we need to progress. We move on to the next program of the day. Unfortunately, Dr. Abhay Delvi, President ASI, could not join us. He has sent his regret message as well as he has sent appreciation to the activities of Surgical Society of Bangalore. I would take this opportunity to ask Dr. G. Siddesh, President-elect of the ASI, to say a few words.
Good evening, everybody. I'm indeed feeling very elated to be part of this prestigious evening of Surgical Society of Bangalore, the Bangalore City branch of Association Surgeons of India. I see a lot of my dear friends here. Of course, the present office bearers, Venkatachala and Harish, they have done a splendid job in keeping up the tradition of the Bangalore Surgical Society, which is one of the biggest city branches in the country. Biggest in the sense, what I'm saying is not in numbers. Numbers, well, Bangalore had to have numbers because of the size of the city, because of the number of medical education institutions which are existing in Bangalore, which is probably one of the, again, it is, I think, the largest in the country again. So by that, we need to have more number of surgeons practicing in Bangalore, I agree. But when it comes to bigger in the sense of the quality of work which is going on, which is again one of the biggest in the country, what I feel. And also the type of the academic activity which is continuing time and again. instituted by our erstwhile leaders. I was talking to my dear friend Ramdev here. He was telling the rich tradition on which this type of program has been built up. It was originally only Professor Adhikeshulu Memorial Oration was there. Then, of course, it was added on with the every year annual oration included Professor B. Hanumaiah's oration. So this has become more glittering and meaningful. And this evening today, it is not just a completion of a formality or a continuation of the tradition, what has been done. It is not just that. I can see the befitting way the orations have been delivered by the experts. So that is what really matters for this continuation and improvement. And today we had Dr. Nagaraj telling, I have my highest appreciation for his skill sets. I think the students who have worked under him are really blessed. I like what he told, if you had to be attached to an institution, a medical institution, you have to have inculcate the art of giving your skills, passing on your skills to the next generation. So that comes from your heart. You may be an extraordinarily brilliant surgeon. You may have a very good vocabulary to communicate, but unless you have a heart to give it, that will end with you. So I think Dr. Nagaraj's skill will continue in hands of his own students ever they continue. So that is where, so he will continue to work and serve the society at a much larger capacity. When I come to Dr. Rajshekhar Reddy, I think his oration was really an eye-opener for those who want to take up. I think general surgeons, as general surgeons, we are apt and well versed with laparoscopic skills. To extend that arm to become a thoracoscopic surgeon, I don't think it doesn't require much of added skills. Of course, nearly 30 to 40% of added skills would be there, which we can always get it by good training and exposure, what he told. And I am very happy that we were also one of the first to start thoracoscopic work way back in early 2000. And we did present in Pune National Conference our early experience of 36 cases, mainly sympathectomies and decortications and debridements. But what I am saying is, when you have a skill set and an equipment, we can extend this. But what is most important, as you put it rightly, you need to find a good combination of your anesthesia colleagues who can support you. So ultimately, again, it's up to you to build the team. You can deliver better at a bigger capacity. And what is really heartening to see is Rajshekhar Reddy has given us a real insight to what you can do addition to being surgeons. Is becoming entrepreneurs or also money changers or money growers. So whatever way you want, you do whatever you want, but you derive pleasure out of what you do. I think don't get into too much of a stress going behind money. I think, but he has a meaning or really a thought process which has been put into your mind. You can pursue those in those lines. I again take this opportunity to thank the organizers for having given this opportunity to stand in front of you and share some of my views. And also this august audience is consisting of senior stalwarts like Rajan sir, sitting here, Dr. Lakshman, who have immensely contributed to ASI at the national level for so many years. And these two individuals are part of our ASI regional refresher course and the TAISA. And I'm very happy to say Karnataka has given maximum number in that group of 6. We have 4 of us, I think. Is it, sir? So that shows again the amount of willingness to contribute for academic learning coming from Karnataka. I think my kudos to this real sense of appreciation when I'm on the eve of when I'm going to take over as the President, I would request them to continue in their efforts and guide us to take this academic teaching, in this era or in this period where learning has really been very difficult because of the COVID, where we would like to take more guidance. And I would request many others to join in with your suggestions, valuable, and whatever way you can contribute. So that is what I am trying to put forward. Use my presence at the ASI. I am there for you. You have made me the president. So you are all part of my leadership. So belong to this ASI. I think we can contribute, we can learn ourselves, and also make others learn out of this process and ultimately help the mankind. And lastly, coming to the advice to the association, I don't say advice, I can definitely say, because I have gone through that process from the lowermost ebb of the association building. Like I have been one of the founder member of the Surgical Society of Mysore. Then it was ASI Mysore City branch, and later on, now coming to the state chapter, and now I'm standing in front of you as vice president, going to be the president of Association Surgeons of India. So my only cue is Bangalore Surgical Society has all qualities to be the best city branch of Association Surgeons of India. I think I request the time and again, every time, I would be very happy to see this city branch taking up this coveted award. And that only shows you will continue to do this in a better way to the years to come. And lastly, accounting is something which is, as a city branch, you need to keep the accounting. I am sure, being one of the very big branch, you are doing with the accounts. I am telling this to all the branches which I am visiting. So I aim to visit as many branches in this particular year of Karnataka at least, so that I can guide them to build up their way and guide them to maintain their accounts and transparency and report those accounts, audited accounts every year, because there is a gap there. We are not yet done. We will be only concentrating on the academic activities, because this present government is not keeping quiet with our accounting system. They're going to come after our back, especially because we request them to exempt us from tax. So, and we use that PAN card for various of our activities. So we are bound by this law to keep our accounts straight. I'm sure ASI, Bangalore City branch is one of the very well kept accounts I see, but this is one suggestion which I'm taking as a general to all the branches. And if I have not left behind anything, again, wishing you all the best for your future undertakings. And next year, this annual conference of Association Surgeons of India is going to be virtual again this year, which all of you must have known. Still, the registrations are open. Kindly register with a nominal 500 rupees. It has been made kept low. And for postgraduates, the registration is free of cost. Please pass on this information, but registration is a compulsory thing. And it is online. The last date of submitting papers have been extended, but of course it is now come to an end, I think. Now, whatever papers we have said, we are in the process of assimilating the data with the help of some of the seniors here. So it is going to be a virtual conference between 17th and 19th of December. It's a virtual conference. Our host will be, the host of the conference is at Coimbatore. We are thinking that at least it is not a hybrid conference, at least the principal office bearers and few others can be present in Coimbatore, so that we can coordinate and bring out a smooth running of this conference. So with this, I wish, and I bring greetings from my president, who has not been able to be present physically here, Dr. Abhay Dalvi. He has sent his greetings to all of you from the Association Surgeons of India. Thank you very much, and happy, and also Thanks for giving me this opportunity to share this few words. Thank you.
Thank you, Dr. G. Siddesh, for those kind words. We now have a couple of awards and certificates to be given out. We have the Millennium Gold Medal Award for 2021. I'd request Harish, the Secretary of SSB, to come over and do the honors. Also, the Quiz Masters of the Dr. K.S. Shekhar KSC 2021, the Quiz Masters are also being given certificates, so just be ready. I request Dr. G. Siddesh and the office bearers to kindly come on the dais and felicitate the winners.
So we have conducted the Millennium Gold Medal Award Papers 2021 as a part of the CSE program on Tuesday. So the best paper selected by our judges is Timing of Bowel Anastomosis in CRS with IPAC, Does It Matter? By Dr. Rohit, Consultant Surgical Oncologist from Manipal Hospital. Welcome, Dr. Rohit, to the stage. Now I call upon Dr. K.S. Shekhar quiz conducted on Wednesday as a part of the CSEP program. It was a well-conducted quiz and appreciated by all the members of Surgical Society. So I call upon Dr. C.S. Rajan, Dr. Lakshman, and his team to command the dais. Dr. Manish, Dr. Nishant, Dr. Khan, Osni Khan, Dr. Wasim, Dr. Niranjan.
Once again, we thank Dr. Rajan, Dr. Lakshman, Dr. Nishan, Dr. Hosni Khan, Dr. Niranjan. Thank you.
And I also thank Dr. Gurushantappa from KCSI as a part of the case Shekhar state level quiz.
We are at the closing part of this today's program. We are going to wrap up with
I forgot to mention about the contributions of Dr. H.V. Shivram, who has been serving ASI as a EC member from Karnataka, but this time he volunteered to step down. Otherwise, he would have been automatic choice anyway. But his role in ASI contribution will continue.
Dr. Siddesh, please stay back. Can we have a memento for Dr. Siddesh from the Surgical Society of Bangalore? Dr. Harish and Dr. Venkat can do the honors. Ladies and gentlemen, the chief guest and the guest of honor and the president-elect, Dr. G. Siddesh. We don't have Dr. Sendil with us, who was also part of the quiz team. He is currently in UK. I request now Dr. Harish, Secretary of Surgical Society of Bangalore, to propose the vote of thanks. And after this, we'll have the national anthem. And I request all the EC members and the office bearers to stay back for a photo session with all the dignitaries. Dr. Harish.
Good evening, one and all. It's my privilege and honor to propose a vote of thanks on this annual Orations 2021. It's my great honor to thank Dr. Abhay Delvi, President of ASI, in his absence. Hearty gratitude to the guest of honor, Dr. G. Siddesh, for your valuable presence, sir. Surgical Society Bangalore is thankful to Dr. H.K. Nagraj for delivering Professor Hanumaiah Memorial Oration. And we are thankful to Dr. Rajshekar Reddy for delivering Professor Adikeshwal Oration. We are grateful to the members, family members of Professor Hanumaiah, Dr. Sharat Chandra, Mr. Balachandra. They are here. And also thankful to the family member of Professor Adikeshwalu, Dr. Jayarajan. I thank Dr. Kalaivani Madam, Dr. Venkatesh KL for introducing both the orators. It's a great honor to thank our senior surgeons. They are the motivators. They are everything behind this program. Dr. Ramdev sir, Dr. Lakshman, Dr. C.S. Rajan, Dr. Chalani, endless. Dr. Shivram, it's endless. They're like youngsters, they are behind us. In each part, they have guided us. So we are so thankful to you, sir. I thank all the members of Surgical Society Bangalore, executive committee members. They have given a full support to make this program successful. It's my privilege to acknowledge the contribution of the volunteers, the hotel staff of the capital, and our friends. And I am also thankful to Mr. Glenn. After he recovers from his health, he worked day and night to make this program successful. I'm so grateful to Mr. Glenn and Mr. Kumar. Surgical Society Bangalore, grateful to the medical companies, Microlabs Private Limited, Mata Associates, and Numed Diagnostics for their contribution. I thank one and all you present here to make this program successful. Thank you. Good evening.
Thank you. Now we wrap up this session. I request all the Surgical Society office bearers to come on the stage along with the two orators and the guest of honor. Okay. So,
अधिनायक जय हे भारत भाग्य विधाता
पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे Thank you one and all. Please join us for fellowship and dinner. I request the office bearers and the dignitaries to come onto the dais for a photo shoot.